Vanakkam. Who says you cannot learn while having fun? Welcome to the Great TANPAPS Quiz, the infotainment program in the run-up to the annual conference of the Tamil Nadu and Pondicherry Association of Plastic Surgeons to be held from February 9 to 11, 2024. Question number 1. Dr. Harold Gillies was a surgeon who had specialized in plastic surgery, general surgery, ophthalmic surgery, ENT surgery. The correct answer is ENT surgery. In 1915, during World War I, the New Zealand otolaryngologist Harold Gillies was working in France on behalf of the Red Cross at the Val de Grace military hospital with Hippolyte Morestin and Valadier. On return to the UK in 1917, Gillies established a centre for the management of face and jaw injuries at Queen's Hospital, Sidcup, and treatment was provided to British and Allied soldiers wounded in the Battle of Somme. Gillies reported his experiences in Plastic Surgery of the Face, issued in 1920, and he used mainly tube pedicle flaps, which had been described by Filatov. Question number 2. A mallet finger injury can develop the following deformity with time: boutonniere deformity, swan neck deformity, hook nail deformity, or clinodactyly. And the correct answer is the swan neck deformity. The swan neck deformity develops following a mallet injury, but the time of occurrence is varied. It can occur quite early after a traumatic, untreated mallet finger if the PIP volar plate is lax. It can occur a little later when the soft tissues become lax slowly, and it can also occur when the mallet injury has healed with an elongated scar. Let us just try to understand how this deformity occurs following a mallet injury. When there is an injury to the terminal tendon inserting into the base of the terminal phalanx causing a mallet injury, the proximal end retracts and does not transmit any more of the extensor forces. This causes a slight proximal migration of the dorsal extensor expansion. So all the forces of extension are now acting at the level of the PIP joint. This increased force also acts on the lateral slips and makes them come to the dorsal aspect. As they come to the dorsal aspect, they begin to lie dorsal to the joint axis. And when they lie dorsal to the joint axis, it means they become extensors of the PIP joint in addition to the already powerful central slip. So that is how the swan neck deformity, that is hyperextension at the proximal interphalangeal joint, develops following a mallet finger injury. Question number 3. According to Cormack-Lamberti classification, flap based on multiple small perforators that run along a facial septum, including the supplying artery in the flap, is type A flap, type B flap, type C flap, type D flap. The correct answer is type C flap. Cormack and Lamberti classified fasciocutaneous flaps based on vascular anatomy in 1984. If the flap is supplied by multiple fasciocutaneous perforators that enter at the base of the flap and extend throughout the longitudinal length, it is a type A flap. This flap could be based proximally, distally, or as an island flap. If there is a single fasciocutaneous perforator which is of moderate size and fairly consistent, it is a type B flap and usually intended for use as a free flap. If the flap is based on multiple small perforators that run along a facial septum and the supplying artery is included within the flap, it is a type C flap. This again may be based proximally,
distally, or as a free flap. The type D flap is an osteomusculofasciocutaneous flap based on multiple small perforators. So it is similar to type C flap but includes a portion of the adjacent muscle and bone. It may be based proximally or distally on a pedicle or as a free flap. Question number 4. The main blood supply of the pectoralis major myocutaneous flap is thoracoacromial artery, pectoral branch of lateral thoracic artery, long thoracic artery, second and third intercostal perforator arteries. And the correct answer is thoracoacromial artery. The blood supply of pectoralis major muscle is mainly from the thoracoacromial artery and the pectoral branch of the lateral thoracic artery. But when it is raised as a pectoralis major myocutaneous flap, it is based on the thoracoacromial artery, which is more dominant and consistent. This flap can be designed with the skin paddle overlying the muscle, which can be transverse, vertical, or crescent shaped. Question number 5. The muscle sparing latissimus dorsi flap is based on the transverse branch of the thoracodorsal vessels, descending branch of the thoracodorsal vessels, main trunk of the thoracodorsal vessels, transverse scapular branch of the thoracodorsal vessels. The correct answer is the descending branch of the thoracodorsal vessels. The muscle sparing latissimus dorsi flap is based on the descending branch of the thoracodorsal vessels, and this flap was described by Saint Cyr. The skin paddle may be oriented vertically or horizontally. The dissection of the flap begins caudally. The latissimus dorsi muscle is split vertically. The dissection stops just before the bifurcation of the thoracodorsal artery, and this is approximately 5.1 centimeters from the posterior axillary fold. The width of the LD muscle that is harvested along with the flap is only about 3 to 4 centimeters. Question number 6. Daily caloric requirements in patients with major burns. By calculating 25 into body weight in kilogram plus 40 into percentage of the body surface area burned is Cureri formula, Harris-Benedict formula, Galveston formula, Toronto formula. The answer is Cureri formula. The Cureri formula is used for calculating the caloric needs in major burns. For age 16 to 59, it is calculated by the formula 25 into weight in kilograms plus 40 into total burned surface area. For patients more than 60 years of age, the formula 20 into weight in kilogram plus 65 into total burned surface area is calculated. The Harris-Benedict formula is used to calculate the basal energy expenditure. The Galveston formula is used in pediatric burns to calculate the fluid resuscitation that is required. That is 5000 ml per square meter of burn surface area used as resuscitation fluid and 2000 ml per square meter total burn surface area as a maintenance fluid. The Toronto formula is used to calculate energy requirements, and this takes into consideration the burned surface area and the post-burn day also.
Question number 7. The thumb has the following pulleys for the flexor pollicis longus tendon: 2 cruciate pulleys and 1 oblique pulley, or 2 annular pulleys and 1 oblique pulley, or 3 annular pulleys and 2 oblique pulleys, or 2 annular pulleys and 1 cruciate pulley. And the answer is 2 annular pulleys and 1 oblique pulley. The retinacular component consists of three pulleys: the A1 pulley, the oblique pulley and the A2 pulleys. The A1 pulley is located over the metacarpophalangeal joint of the thumb, the oblique pulley over the proximal phalangeal region and the A2 pulley over the interphalangeal joint.
Question number 8. What is the artery being denoted by the arrow? Lateral circumflex femoral artery, ascending branch of LCFA, transverse branch of LCFA, descending branch of LCFA. The correct answer is the transverse branch of the LCFA. The tensor fascia lata myocutaneous flap is supplied by transverse branch of the lateral circumflex femoral artery. This dominant pedicle is located 8 to 10 centimeters below the anterior superior iliac spine. The anterior arc of location will reach the abdominal areas, groin and perineum. The posterior arc can reach the greater trochanter, ischium, perineum and the sacrum. Question number 9. The following is a feature of classic extrophy of bladder: hypospadias, diastasis recti, premature fusion of pubic symphysis, normal pubic escutcheon. The correct answer is diastasis recti. The following are the features of classic extrophy of bladder: epispadias, diastasis recti, absence of fusion of pubic symphysis, and deformed pubic escutcheon. Question number 10. Abdominal compartment syndrome is considered when the intra-abdominal pressure more than 20 millimeters of mercury, more than 40 millimeters of mercury, more than 60 millimeters of mercury, more than 80 millimeters of mercury. The correct answer is more than 20 millimeters of mercury. Abdominal compartment syndrome is a life-threatening situation associated with fluid extravasation or edema and over-enthusiastic fluid resuscitation. It is defined as intra-abdominal pressure more than 20 millimeters of mercury and at least one new organ dysfunction. It can be associated with renal impairment, gut ischemia, and cardiac and pulmonary malperfusion. The clinical manifestations are tense abdomen, decreased pulmonary compliance, hypercapnia, and oliguria. To increase the abdominal wall compliance and decrease the intra-abdominal pressures, appropriate intravascular volume must be re-established, appropriate body positioning needs to be done, pain management must be done along with nasogastric decompression if necessary and torso-eschorotomy if necessary.
I hope you liked the video. I enjoyed making it. Please register for the TANPAPS 2024 conference, a wonderful scientific and academic feast where many innovative and interesting sessions are being planned. Do visit the website to see the details and to register. Vanakkam.